symptoms of this condition, review potential functional limitations that we just learned about, identify tests and measures used for diagnosis, discuss differential diagnosis of Piriformis syndrome, and I'm going to discuss the likely outcomes. So what is Piriformis syndrome to start with? So this syndrome affects the sciatic nerve and the piriformis muscle. So it is a compression of the sciatic nerve and is typically described as radiating pain from the gluteal region to the posterior leg. And as you can see in this picture I provided on that slide, the piriformis muscle is compressing the sciatic nerve. So some causes of why this happens, one being trauma to the sacroiliac or gluteal region, and this results in a hematoma formation and scarring between the sciatic nerve and the external rotators and the piriformis. The next would be a hip flexion contracture, and so this contracture increases lumbar lordosis, which then increases the tension in the pelvic femoral muscles, and this tension that's in these muscles causes hypertrophy and leads to the sciatic compression. And the next one, as I have on here, is hypertrophy of the piriformis, which I just described in the hip flexion contracture as well. And the most common cause of Piriformis syndrome, according to Dutton, is overuse, and this is just when individuals keep doing the same activity that first onset or provoked these symptoms. The next cause would be abnormal anatomy, which that would be like if a patient has scoliosis, comes into a clinic with scoliosis, that's compressing the sciatic nerve down to the SI joint. And this is more common in females than it is males. So some clinical manifestations and functional limitations of this. So for the signs and symptoms, most patients report pain, as Dr. Carr just kind of elaborated. And they usually have this pain with prolonged sitting, or if they're walking on an incline, such as like a hill up the stairs, anything just with an incline. And they typically describe their pain as persistent and radiating and hard to localize. Some more signs and symptoms would be inflammation, decreased range of motion, decreased endurance and strength, gluteal atrophy, muscle spasms, and abnormal gait patterns. So some functional limitations that will go along with these signs and symptoms is unable to sit for a prolonged period of time. So like as we're all just sitting here, we would just be tossing, turning, like having to situate ourselves because it would be painful for us to sit. They would have difficulty ambulating. Many patients reported pain getting in and out of the car, flexing and extending, just repetitive movements like that. Difficulty sleeping, as I kind of elaborated with us sitting here, like we just would have to keep moving to get situated. With sleeping, it would be hard for them to like sleep on their back, sleep on their side. They would just have to toss and turn all night. And also a big one is limited walking distance, because they would get tired and their muscle endurance would be not where it's supposed to be, so they could not walk for a specific period of time. So on the next slide, we're going to talk about tests and measures. So obviously as physical therapists, we're going to assess their passive range of motion and active range of motion when they come into the clinic. An EMG study is also seen to be beneficial. In the MRI of the lumbar spine, if nerve root compression is suspected. Manual muscle tests and muscle selective tension tests. Stretching the piriformis is a main one we would do in the clinic. Putting your leg across and like slumping over, and also laying supine, and the therapist maximally flexes the knee and the hip. And an indication would be pain radiating down the leg, indicates Piriformis syndrome usually. Special tests that would be performed is the Faber test, the 90-90 straight leg raise, the Piriformis test, and also the FAIR test, which the FAIR test is flexion, adduction, and internal rotation. So on the next slide, I have a table that I copy and pasted from Dutton, similar differential diagnoses for hip pain. So as you can kind of see in this graph, a hamstring muscle tear would mostly be about the same as piriformis when you look at it in this graph, because it both has areas of symptoms in the gluteal region and the posterior thigh and the back of the leg. But what separates these two is that a hamstring muscle tear would be a sudden overload, whereas with the piriformis syndrome, it's kind of gradual. It just happens over time, and what symptoms aggravated usually by prolonged sitting. So the rehabilitation process for an individual with piriformis syndrome, during the max phase, the early acute phase, the number one thing is patient education. The next, we would perform passive range of motion and gentle isometric exercises. And according to Dutton, one of the big things for the beginning phase of piriformis syndrome would be stretching and modalities such as like an ice massage. During the moderate phase, we would progress to active range of motion, and we would start to kind of isolate the piriformis in the gluteal region and train that muscle. We would work on hip mobility exercises and perform manual therapy as well. And during the minimum phase, when they're returning back to function, we would progress their strengthening, start to work on their core stabilization. We would begin endurance training and get more functional movement exercises involved. So as you can see on this next slide I attached, this is typically some of the exercises you would perform for an individual that has piriformis syndrome. So the gluteal stretch, you would typically begin that early in the max phase. The prone hip extension, that's kind of isolating the gluteal region. So you would, that would kind of be more of a moderate phase exercise. And the quadruped arm leg raise, which we all probably know as bird dogs, that would be more of a core stabilization and kind of more of an endurance. You can make that more of an endurance exercise, so that would be more of a minimum phase. So some likely outcomes for somebody with piriformis syndrome is that it typically resolves quickly with treatment. Symptoms improve within days to weeks, and the condition does tend to come back if the patient does not follow instructions and begin to go back to the activity that began this, such as like riding a bike, walking on an incline on a treadmill for a while, just things of that nature. So our overview for today is that piriformis syndrome involves the sciatic nerve and the piriformis muscle. There are several causes, pathomechanics of this condition, but typically overuse is one of the main one we see. It is more common in females. Pain is exacerbated by prolonged sitting. Avoid overuse injuries, which is kind of goes along with the patient education that we will be providing to the patient when they see us. Stretching and strengthening are key to relieving pain and compression, and patients are expected to make a full recovery if they follow protocols. And there's my references. Does anybody have any questions?
I have a question.
I was waiting on it.
How would you differentiate piriformis syndrome from lumbar radiculopathy?
Just perform special tests that may rule out like low back pain, and isolate more of the piriformis during your test.
Okay, so you got something there.
Yes, sir.
Go back to what you said before. You perform some special tests isolated to the
That
lumbar
isolates
spine,
the gluteal and piriformis.
and then you would perform something that isolates the gluteal and piriformis.
Yes, sir.
Okay, so what would you do with the lumbar spine to rule out lumbar radiculopathy?
Slump test.
Okay, slump test. Anything else?
That's all I can think about right now, but I will get back with you on that.
Okay, good. That's good. Slump test. Also, always remember, we look at movement. So your repeated movements of the lumbar spine.
Yes, sir.
So never forget about those, because the repeated movements are gonna give you information as well. And so you can always count on those to kind of give you some information and kind of direct you in the next direction you wanna go in.
Yes, sir.
So typically with sciatica, And if you wanna differentiate lumbar radiculopathy, typically, to rule out lumbar radiculopathy very quickly, you can just do repeated movements of the lumbar spine.
Yes, sir.
And so, if they don't have any type of lumbar radiculopathy, most likely all your repeated movements are gonna be negative, and they're not gonna refer pain down the lower extremity. Then you can go down, so that's a quick way to just screen and rule out the lumbar spine, and rule out lumbar radiculopathy. Because if they do have a true bulging disc or stenosis or something going on in the lumbar spine, the repeated movements are gonna likely reveal it.
Yes, sir.
They're gonna likely reveal it. So if the repeated movements are negative, then the patient said, man, I can do all these movements, no problem, full range of motion, but they still have ridiculous symptoms, then you can go to the Piriformis. But also you can ask them, you can kind of get a glimpse in your history taking, and you can ask them, where does the pain start? Most of the time with Piriformis, they typically state that the pain starts in the buttock region, in the buttock area. So that's another way you can differentiate as well. Anything to add, Dr. McClure?
Just a comment. So one thing I've seen this commonly several times with patients, think about